Hi, my name's Jessica Hassauer, and I'm the Executive Director for Minnesota Network of Hospice and Palliative Care. Thanks for tuning in to help MNHPC celebrate our 40th anniversary. We're so glad you're here. Tonight, we will honor our past and we will look to our future. You will hear from longtime friends of MNHPC, Loris Volomnik and Dr. Vic Sandler. Loris Volomnik is the Principal Consultant with Loris Consulting, and she's the lead nurse planner for the MNHPC Education and Training Committee. Dr. Sandler is the Associate Medical Director for Fairview Hospice, and he chairs the MNHPC Hospice and Palliative Physicians Committee. Both Loris and Vic will talk about their professional journeys through hospice, and they'll share their personal experiences as well. You'll also hear from MNHPC board member and St. Croix Hospice chaplain, Zach O'Neill. The heartfelt presentations that you'll hear tonight really capture the spirit of our organization and our movement. They speak to the value of hospice, they reflect on what matters most, and they focus on the power of coming together in service of a cause greater than our individual selves. 40 years ago, a small, dedicated group of Minnesotans joined together to support their colleagues working in serious illness care. This group of individuals saw the struggles of patients and families at end of life, and they said, "We can do more, we can do better." This small group of innovators saw promise in a new model of care called hospice. So they rolled up their sleeves and they traveled across the state establishing hospice programs, and they formed Minnesota Network of Hospice and Palliative Care. The grit and grace of Minnesota's hospice and palliative care movement is needed now more than ever. In the midst of a global pandemic and with calls for racial justice, MNHPC is providing education on key topics such as how to manage the respiratory symptoms of COVID-19 patients, how healthcare professionals can advocate for more equitable care, and how families can safely visit their loved ones in nursing homes during COVID-19. MNHPC is supporting hospice and palliative care providers on the front lines providing care, and we're advocating for patients and families. In these challenging times, it helps to remind ourselves of what is possible when we come together and seize the opportunity for change. We envision a future where we openly discuss our hopes, fears, and goals regarding serious illness, death, and grief. We envision a future where healthcare professionals are trained to communicate openly, honestly, and with empathy. We envision a future where the pain and stress of serious illness is expertly managed and the needs of caregivers are met. And we envision a future where healthcare disparities are eliminated and everyone has access to high-quality serious illness and end-of-life care. Together, we will build this future.
Thank you for this opportunity to speak to all of you on behalf of MNHPC and tell you my story. In the past 6 months, our 2 daughters have gifted us with 2 beautiful baby boys, our first 2 grandchildren. Sadly for us, both of our daughters live in New York City. So we have not been able to be with our grandsons and hold them in our arms for the past 4 months because of this awful pandemic. Thank God for new technology, which has allowed us FaceTime visits with our daughters and their sons, Howie and Thomas. My 2 new grandsons are blessed to have 4 healthy grandparents each. That is very different from my childhood. I really had only one grandparent that was part of my life. One died many years before I was born. One died the year I was born. One lived in Florida. I saw him only a few times before he died when I was 8. My grandmother, my dad's mom, lived in North Minneapolis. She was the only one of my grandparents that I really got to know and to love. She was a remarkable woman who immigrated to this country when she was 19 with 2 small children in tow. She gave birth to my father in New York City. My grandparents and 6 of their 7 children moved to Minneapolis when my dad was 7 years old. The remarkable thing about my grandmother was her character. She raised 7 children, mostly on her own. Her husband, my grandfather, had chronic mental illness. He was institutionalized. My father and my aunts and uncles loved their mother deeply, but they almost never mentioned their father. This woman, of very little education, raised 7 children during the Great Depression. Through her grace and love and kindness, she taught them all about human dignity. And through my father and from her directly, I absorbed these lessons. I loved her, but more important, I cherished who she was. My grandmother died when she was 79. At least we think she was 79. No one exactly knew what her birth date was in Russia. She was buried on my 17th birthday. I remember that day very clearly, walking from her graveside and back to the car. I sat in the car and sobbed, deep, wrenching sobs. I believe at that moment my grandmother's spirit was forever bonded to mine. And though I decided when I was 8 years old to be a doctor, I'm sure that it was the lessons that I learned from my grandmother that led me into geriatric medicine. Despite her frailty, this woman had enormous courage, so surrounded by a warm halo of love and warmth that was clear to everyone she encountered. She taught me through her kindness and love to cherish older people. And so my career path in medicine was decided by my grandmother. God bless her memory. My mother and father were the other 2 great teachers in my life. I don't have time to list all the great lessons that I learned from being the son of Helen and Mike Sandler. So I'll focus on the lesson I learned from my parents as they lived out the last chapter of their lives. I moved back to Minnesota in 1980 after completing an internal medicine residency in Massachusetts. My parents were not old at that time, but I knew that one day they would be old, and I wanted to be near so that I could care for them. They loved me and raised me to be the man I was. I needed to be there for them at whatever point in the future they would need me. My mother was diagnosed with metastatic lung cancer in 1998. I thought she would live only a few months. She lived nearly 3 years, but they were a very difficult 3 years. She was very debilitated for most of that time. She suffered a stroke a year after her cancer diagnosis and was totally bedridden for the last year of her life. With great help from my wife and my cousin, 2 wonderful women, caregivers, Marlene and Erin, and of course with the assistance of Hospice, we were able to care for my mother at home. My mother was unable to speak for her final months. Often when she slept, I would sit at her bedside, hold her hand, and pray. Through prayer and the deep love I had for my mother and she for me, I came to understand the essence of God's love. My mother was laid to rest in 2001, September, 4 days after 9/11. It was a time of grief for me and my country. 1 month after my mother died, my father was diagnosed with Alzheimer's disease. My abiding love for my father enabled me to care for him, even as more and more of the man that he was slipped away. Even though I had practiced geriatric medicine for nearly 20 years and cared for hundreds of patients with dementia, it was my closest to my father, and our deep connection, based on my love and respect for him, that allowed us to carry on a meaningful relationship for the next 6 years. My father died in 2007. 1 year before his death, I was asked to become the medical director of Fairview Hospice. Both my work in geriatrics, caring for many patients in their final weeks and months of life, and caring for both my parents made it clear to me that this invaluable work would be my choice for the last chapter of my career. Fairview made their offer conditional on my taking the board certification exam in hospice and palliative medicine. This would not be offered actually until 2008 for the first time. I thought to myself cavalierly, well, that'll be no problem. I've been boarded in internal medicine and geriatric medicine. I've cared for many hospice patients. I've consulted on end-of-life ethical issues for 20 years. I could probably take the exam right now and pass it. But when the exam date approached in 2008, after spending 2 years exclusively caring for hospice patients, I had learned that palliative medicine encompassed a very large body of knowledge. I studied intensively for 4 months and I passed the exam. 2 years ago in 2018, at the age of 68, I was required to retake the exam to maintain my certification. I studied intensively again and passed it again. I asked a good friend who is also a doctor, Mitch, if I take the exam again in 2028 at the age of 78, do you think I'll get in the Guinness Book of World Records? Mitch said, Vic, if you're a hospice patient at the time you take the exam and you pass it, then maybe you'll get in the Guinness Book of World Records. Well, I think the bottom line is I'll rest on my laurels, and I don't think I'll get in the Guinness Book. I have now practiced hospice and palliative medicine for 14 years. Since I ended my office, hospital, and nursing home practice of medicine, I often run into friends and physician colleagues. I get the same 2 questions. First, they ask, Vic, how's retirement? And I respond, I'm not retired. I've been caring for hospice patients full time for the last however many years. Then they say, that must be very depressing work. And I say, it's really some of the most gratifying work I've done in my 40 years of medical practice. I visit patients and families in their homes. They're more comfortable because they're in their environment, on their turf. I get to spend the necessary time to understand them and answer their questions, address their fears, reassure them that we will be their guide down this path that they and their families have never walked before. How am I able to be so reassuring, you might ask? Well, you should have the opportunity to meet and get to know the people I've worked with for the past 14 years. The nurses, the social workers, chaplains, music and massage therapists, and of course, the wonderful volunteers. They are some of the kindest and most competent people I have ever worked with. I'm guessing that many of them were blessed with a grandmother like mine. Elizabeth Kubler-Ross wrote a book a number of years ago entitled Death, the Final Stage of Growth. The title of the book really captures the essence of the work that we do in hospice and palliative care. Our goal is for our patients to live until they die, for their families to be left with memories of closeness, connection, and finally peace as they care for their loved ones. So when Becky, one of our music therapists, tells me that the nonverbal Alzheimer's patient sang joyfully with her as she joined Becky singing a song from her childhood. When our nurse Peggy tells me with tears in her eyes how hard it will be for her when her patient dies because of the closeness she has developed to him and his wife during the months that she has guided his care. When Sheila, one of our social workers, tells me that a patient and family that she is admitting to hospice needs my help now, I know that her insistence comes from her devotion to her patients, which means I must help now. And when our chaplain Phyllis reads a prayer or poem at our hospice team meeting, it gathers our spirits together so we can go forward with our work with both hope and resolve. Our team is uplifted. These are the kinds of people that I am blessed to work with. And so it went for the last 14 years of my work life. My team of nurses, social workers, chaplains, therapists, volunteers, and doctors working together to care for our patients and their families, to teach and to guide, to lessen the pain and the suffering, to follow the ideals that Elizabeth Kubler-Ross established for our work many decades ago and give these patients and their families one more opportunity for growth before each of these patients goes the way of all flesh and meets their maker. But then everything changed 12 weeks ago. Minnesota was hit by the pandemic. The therapeutic touch that is so much a part of our work was blocked by the physical distancing that was mandated to forestall the spread of this deadly virus. I could no longer hold the hand of my patient as I answered his or her questions, calmed her fears about what lied ahead. In fact, I couldn't even go into their homes. Our nurses could no longer give the comfort of a supportive hug to a tired caregiver. Our massage therapists were furloughed altogether because everything they did to relax the tense muscles and reduce the pain of so many of our patients was no longer permitted. The pandemic forced us to change. Our mission had not changed, but our methods had to change, both to protect our patients and their families and to protect our hospice staff and their families. Our nurses donned masks and protective equipment to slow the spread of the virus. Their touch was through latex gloves, and their supportive smiles were hidden by surgical masks. My visits, the visits of our chaplains and our music therapists, were no longer in person, but were displayed on video screens. Despite Medicare and the Minnesota Department of Health guidance, we found that our hospice nurses were at times barred from seeing their patients within long-term care facilities. But a wonderful thing happened. I discovered, and all our hospice staff discovered, that our patients and their families, though they could no longer see our smiles or receive our hugs, could still see our eyes, the windows to our souls. They could hear the kindness and compassion in our voices. The benefits of the critical care that we provide to patients and families could still be delivered and received. Though I could not be there in person, and I would apologize for that to my patients and their families, they could see my face and hear my voice. Our talented hospice nurses would help us focus the issues to be addressed and act almost like movie producers, directing my attention to the patient or the family member, or even the patient's abdomen, which I could examine, in a manner of speaking, through the hands of my nurse and the video projection that she provided. COVID-19 brought increased demands on hospice and palliative care around the whole country. State and national organizations stepped up and provided resources so that clinicians would have the tools for both communication and treatment. We faced the prospect of patients requiring urgent advanced care planning so they and their families could determine what types of treatments they did and did not want. For patients that did not want aggressive treatment, nursing homes and providers needed urgent guidance on relieving rapidly developing symptoms of shortness of breath or pain suffered as a result of this virus. With the facilitation of Jess Hassauer and MNHPC, we marshaled our expertise and our energies to focus on the problems at hand. The Minnesota Network of Hospice and Palliative Medicine Physicians, with the organizational support of MNHPC and Jess's direct facilitation, met weekly to troubleshoot problems and recommend solutions to the problems that we faced. We were doctors from health systems all around the state, usually in competition with each other. But yet there was sharing, there was caring, there was collaboration. We created a guide for emergency treatment and symptom management for COVID-19 patients within skilled nursing facilities. We authored a guide so that these same facilities would provide timely end-of-life visitation between family members and their loved ones. And we partnered with Minnesota Department of Health, Leading Age of Minnesota, and Care Providers of Minnesota to implement these measures. I believe this pandemic has crystallized for our community the vital importance of the work of hospice and palliative care. The health professionals that practice hospice and palliative care have always collaborated with each other because that is the very nature of our work. We understand that all members of the healthcare team are vital in treating our patients with serious illness and maximizing the quality of life for both our patients and their family members. It is my hope that my physician colleagues in other medical specialties, many of whom have not studied or appreciated the value of our work, are now realizing that value of what we provide to their patients. Through the vital work of MNHPC and each of us individually that provide hospice and palliative care, and sadly, because of the tragic reality of this pandemic, I believe we can better the last chapter of more lives. For all of us once had grandmothers. I hope yours, like mine, was a woman of grace and valor. Let us do this work in their memories. Thank you.
Good evening. This is Loris Valamic joining you tonight virtually. Oh, I'm so used to wearing this mask, I forgot. I'm at home. I don't need to wear this, so I'll get to talk to you directly. Who would have thought 6 months ago we would be dealing with COVID-19 and how we would need to adjust the hospice services that are provided in the palliative services. But I'm going to start with sharing a few memories of my own and those of some of my colleagues in how hospice started back in the late 80s throughout Minnesota. Congress enacted the hospice benefit as a subset for those Medicare bennies that had a terminal illness back in 84 and 85, later expanding it to the nursing homes so that we could provide services in the nursing home. But it was back in 1989 when I approached our board to ask them if they would be interested in my research in the possibility of starting hospice along with our home health care practices and services. They said, sure, check it out. We're not giving a thumbs up yet, but check it out. And so I had an opportunity to visit a rural and a metro hospice agency already in existence. I had an opportunity to attend volunteer training of a neighboring hospice program and came back to that board and said, we need to do this. We have more patients who are requesting home care services, but they're terminally ill. And I'm a nurse, and my nurses are nurses, and we need more of an interdisciplinary team and focus to provide the best possible support, not only for the patient, but for their family. And I'll never forget the executive of our board said, good idea, Loris. Go find the money. When you have half of it, half of your first year's budget in pledges or gifts, then come back and talk to us. And so I embarked, if you will, with a lot of grit and determination to say we can make this happen. But what if we couldn't? That was kind of a lingering fear. But do you know, the train started moving down the track and people got excited about being a part of something good. They didn't always know what it was and what hospice is, but they knew it was good. And what they had heard about services from other persons allowed them to get on board, and that is how it started. I found myself needing more solidarity in our growth, and that is why our agency joined the Minnesota Hospice Organization back then. Because groups of providers met throughout the state of Minnesota and then as a statewide group to exchange ideas, to talk about some of our challenges and our difficulties and maneuvering through health plans to get them on board to say, hey, pay for this awesome benefit for your beneficiary. And so they did. But I remember some of the early growing pains. One of my friends said, we had no durable medical supply company for which to deliver beds, walkers, and wheelchairs. So my husband wired together the truck and we delivered out in wherever it was needed. We often depended on many donations of medical supplies, such as beds and walkers, that we sanitized and then used again. How much that has changed, certainly. I remember our first bag phone as a nurse. And I remember the comfort it gave me, even though it didn't have very good reception and we had to pass it from nurse to nurse at night. And then we had to get antennas actually placed on our cars so that we would have some kind of transmission and reception. But it gave us security because, as you know, with hospice and palliative care, RNs are on call 24/7, 7 days a week. And we're making visits in the middle of the night whenever it is needed to support the patient and the family. We had pancake breakfast. We had raffle tickets. We did so many things in which to try to raise money for hospice, which still is evident today. Because there are supportive services that are not funded by Medicare that hospice programs have found to be beneficial, so therefore they raise dollars for. Typically in hospice, the services of a nurse, a medical director, attending physician, social worker, hospice aides, chaplain counselor, therapies, PT, OT, and speech if needed, registered dietitian, access to a pharmacy, and then we have integrative therapies such as music, animal therapy, massage, and the list goes on. So it can be a whole plethora of wonderful services rendered by those that have expertise in those areas. Well, consider palliative care to be much of what I've just talked about, except that the patient does not need to if you will have a terminal diagnosis, but a serious illness. And so I had the opportunity to experience both of those I'm going to tell you about in just a little with my parents. So palliative care, I would like to say, is sort of in that infancy grassroots development, because yet we have, some major barriers such as funding from the federal government for palliative care in the way we would like to see it rendered, of course. And so we continue in all of these programs with determination and with grit, because we've seen the miracles that happen when supportive services are provided and the patient can step back and be the patient, be the family member, or the family can be the family. And so I encourage all of us to be nimble and flexible as we now go through COVID, where hospice and palliative care programs have had to redefine what it is that they do. When we are restricted from seeing some of our patients within facilities because of the high incidence or potential of COVID-19. We've had to think about telehealth. We've had to think about virtual home monitoring. What does that look like? And hospice and palliative care has typically been high touch. Now we've become more high tech. And to try to find that balance will be something we will continue to explore. A year ago this month, my parents were living in their own home environment. At age 87, 90, my father married for 67 years. My father's body was more frail. My mother's was stronger, but she had dementia. Well, about this time last year, both of them suffered vertebral fractures. Not really know why Dad did, but Mom had a long-standing history of severe osteoporosis. So we knew they were both fit for back braces. They were not to lift, bend, or stoop, or pick up. That they would need more attention than we would be able to give them through intermittent visits. And we found an assisted living less than 10 miles from my house, my sister and my brother, that was absolutely wonderful and the most appropriate place for them to go. They did so without hesitation because they knew they needed a lot more support. But what none of us knew is that after they both then suffered a fall while in the assisted living, both hospitalized within 24 hours of each other, that my dad would be diagnosed with multiple myeloma and Mom, severe osteoporosis. So they both went back to the assisted living because they expressed that would be their preference and their desire after that many years of living together. Who can blame them? So we tried to support them in that endeavor. But as I looked at my father's chart, while in the hospital, we had requested a palliative care consult for him. And an objective nurse practitioner wrote in the chart, Mr. Gingrich may be eligible for hospice. And those words jumped off the chart at me. And I stepped back and I went, well, Loris, you know what hospice is. But I hadn't seen, because you see, my filter in watching my dad was that of the daughter, of concern, and I didn't step back to objectively look at what was really going on. And I thought to myself, of course, we need to ask Dr. J, his attending of 14 years, if he thought that was appropriate and ask for that referral. He made a home visit. As he saw my dad, he was pretty shocked at the change. And then he asked my dad what his preferences were, and I'll never forget. My dad looked at Dr. J and he said, well, my daughter over there, pointing at me, always says that people enroll in hospice too late. And I don't think I'm really that sick, but if you think it's the right thing for me, I'll go along with it. The next day, a hospice RN came out on a Saturday to enroll my dad in hospice. Unfortunately for us, he lived only 21 days after that enrollment. My mother, a witness to his decline but not really absorbing the decline, was real confused by his passing and started not to eat. And I would suggest if there was a code for broken heart that would have been her primary terminal diagnosis. She quit eating. She was so confused about where her husband was, and she would say, "Where's Cliff? Why did he fly away without me? I want to be with him." And as much as we visited, as much as we tried to provide comfort for her, physically she continued to decline. She'd been followed by the homebound palliative care program. And at that time, the nurse practitioner also said to me, "I'm going to keep my eyes open because I think at some point we should think about your mother enrolling in hospice." And that day came, and my mother enrolled in hospice. I cried after each of those admissions, not so much out of sadness, but out of relief. I wanted to be a daughter, not the nurse that couldn't access pharmacies after hours, that couldn't really call someone at 4 a.m. and say, "Now what?" I wanted to be the daughter, but do you know, I learned something. Even as a daughter, trained as a nurse, you can't unknow what you know. And so I worried. And so for me to have that listening ear, that listening shoulder, that listening person to say, "I think we should do this now," and to guide us through next steps was invaluable. You cannot put a price tag on that. My mother and my father both died in the assisted living. And so it was a partnership with the assisted living, hospice, and us as family that allowed them to realize their preference and their wish. That's not going to happen for everyone, but it did for us. And I'm forever grateful for all of the supportive entities that made that happen. So I would like to say, as I watched, as I was the daughter, I looked for compassion. I looked for expertise. I looked for care. I looked for access to the services that was offered, and I saw it delivered. And again, I cannot tell you what that meant on the receiving end. Little did I know that back in '89, what I would learn through the years about hospice, I would then be on the other end, and it came full circle for me. What an experience for me and for my siblings. They often said, "Laura, I know you've done this kind of work forever, but we really didn't know what it was all about," until they were the siblings and the receipt of hospice and palliative care services. They're now believers for sure. So I want to thank you. I want to thank the statewide association, which is now called MNHPC, the Minnesota Network of Hospice and Palliative Care, that supports us as providers, even through COVID, by having weekly and every other week meetings on phone so that we are supported, that we can have an open forum to share what's working well for us in the COVID times, what are some of the challenges, looking for the silver linings. And as I've been a participant of those calls and the educational committees to try to plan what our statewide providers need, I'm always impressed with the expertise of Minnesotans, of the Minnesota hospice providers. And I would just like to challenge them and all of us. We're going to get through this pandemic. We're stronger together if we can be part of an association, if we can reach out and ask our neighbors, how are they doing it, our neighboring hospices. We will be stronger together. And to keep our focus the same as it was way back with Dr. Cicely Saunders, Florence Wald, and others in the birthing of hospice, we're now growing through, if you will, our many years of hospice and collectively pulling those experiences together. Don't lose sight of the grit, of the grace, of the compassion, of the love and the care that called you to this work. Thank you on behalf of me, my family, and my parents for being there. Blessings to you. Bye-bye.
You've heard a lot tonight about the deep need that hospice and palliative care fill. The need for quality, compassionate care for those nearing the end of their lives or facing a serious illness of any kind. Care that provides resources, tools, opportunities for people to make their own decisions regarding how they live and how they die. You've also heard how MNHPC is committed to making this a reality for as many people as possible. We believe that this work is important, that it's vital, that's essential, and it should preclude no one. MNHPC advocates for hospice and palliative care across the state, from densely populated cities with abundant medical availability to more rural areas where medical providers are more than just a stone's throw away. We also recognize that while this kind of work is a privilege, it also takes a toll on our caregivers and providers, the volunteers who walk this very difficult road with their patients and loved ones. And part of what MNHPC provides is this community of support and mutual care for those valuable contributors. Our role is that of community convener, educator, organizer, and leader, providing high-quality education and training for healthcare professions, providing information and resources to the broader community, supporting patients and their families during a tender time in their lives through our helpline, and having conversations around the state, cutting through the stigma and normalizing hospice and palliative care, advanced care planning, that dying is a normal part of life and part of the human experience that we all share. And that serious illness is not the means to the end, but that living life to its fullest and having it abundantly till the very end is. So, as our time winds down, we all seek comfort in simple pleasures. Companionship, being with family, everyday routines, the taste of good food, the warmth of sunshine, a walk in the park. We become less interested in the awards of achieving and accumulating, and more interested in just simply being. While yet we may feel less ambitious, we become concerned with our legacy and the deep need to identify purposes outside of ourselves that make living feel meaningful and worthwhile. In the end, people don't view their life as merely the average of all of its moments, which, after all, is mostly not much, plus some sleep. For human beings, life is meaningful because it's a story. A story is a sense of a whole. It is determined by the significant moment, the ones where something happens. So thank you for being a part of our story tonight. This year, MNHPC celebrates 40 years of pioneering a legacy and the deep need to identify purposes outside of ourselves. As Atul Gawande said, our ultimate goal, after all, is not a good death, but a good life to the very end. We are honored by your support. And we thank you sincerely for considering partnering with MNHPC to make hospice and palliative care available for the thousands of Minnesotans that are dealing with a life-limiting illness each day. You are the bridge between our mission to ensure that everyone has the help they need to live and die according to their wishes, and the actual accomplishment of this desire to honor those approaching death. The COVID-19 pandemic has put a financial strain on many organizations, and MNHPC is no different. As a result, we find ourselves in even greater need for your contributions. Would you join us in our vision with a monetary gift to ensure that we can continue this vital work? We value your partnership, and we look forward to the work MNHPC will be able to continue to do because of your generosity today. So may you be well. May you continue the legacy. May you live a life without regrets and live with purpose and meaning.